When we picture malabsorption, the mind often goes to rare, end-stage systemic failures, patients presenting with severe wasting and chronic diarrhea. But the clinical reality looks different for most practitioners. On the left is the textbook extreme. On the right is the patient with a normal body mass index, presenting only with isolated laboratory abnormalities. The earliest indicators are subtle and easily misattributed. They often present as refractory iron deficiency anemia, early-onset osteopenia, or unexplained peripheral neuropathy. Waiting for gross steatorrhea or severe weight loss to initiate a workup ensures a significant diagnostic delay, leaving the patient with prolonged, preventable morbidity. Recognizing these subclinical micronutrient proficiencies is the first step to identifying malabsorptive diseases before they reach a stage of systemic failure. Once clinical suspicion is raised, the immediate reflex is often to order an unfocused battery of blood panels and endoscopies. This unguided testing is inefficient and leads to unnecessary costs. To be effective, the clinical workup must be driven by mapping deficiencies to a physiological model of the gastrointestinal tract. This funnel is divided into 3 distinct zones: the luminal, the mucosal, and the postmucosal phases. By identifying exactly which zone is failing, we eliminate unnecessary imaging and serology, narrowing the anatomical focus to the specific site of the defect. The physiological location of the defect dictates the entire diagnostic workup. Identifying the specific failing zone is the only way to select the appropriate downstream tests. The first zone is the luminal phase. Here, pancreatic enzymes and bile salts act within the hollow space of the intestine, mechanically and chemically breaking down complex ingested molecules into simple fragments. Maldigestion occurs when this preparatory enzymatic phase fails. The complex nutrients remain intact and unabsorbable, despite the intestine's surface being healthy. The primary structural culprits driving this luminal failure include chronic pancreatitis, where digestive enzymes are deficient, and biliary obstruction, which prevents the emulsification of fats. We also consider functional luminal defects, like small intestinal bacterial overgrowth, or SIBO. Here, excess bacteria prematurely consume the nutrients before they ever reach the intestinal wall. In a luminal defect, the actual absorptive surface of the intestine remains completely intact, but the biochemical preparation of the food has failed. Moving outward, we reach the mucosal phase. This animation shows a healthy brush border, where enterocytes use intact microvilli to actively transport small particles directly across the cell membrane. When this absorptive mucosal surface becomes inflamed, flattened, or structurally reduced, the active transport mechanism shuts down. The classical drivers of this specific mucosal damage are celiac disease, tropical sprue, and parasitic infections like giardiasis. Massive surgical resections of the bowel mechanically mimic these diseases by directly and permanently reducing the total mucosal surface area available for transport. A mucosal defect is a physical loss of the transfer interface. If the mucosa is damaged, the nutrients have no way to cross the barrier, regardless of how well the luminal phase prepared them. The final zone is the postmucosal phase. This graphic tracks molecules that have successfully passed through the enterocyte, only to be loaded into the parallel lymphatic and vascular systems on the basolateral border. In a postmucosal defect, nutrients successfully enter the cell, but are physically blocked from reaching resisting circulation. The primary clinical culprit for this specific anatomical blockage is intestinal lymphangiectasia, where dilated, dysfunctional lymphatic channels trap deabsorbed fats and proteins. If both luminal digestion and mucosal absorption test normal, the diagnostic bottleneck exclusively lies downstream in the vascular and lymphatic network. Before ordering an invasive endoscopy or expensive cross-sectional imaging, there is a clinical mandate: biochemically confirm that malabsorption is occurring. This diagnostic flowchart places stool fat confirmation as the mandatory first gate. Clinicians utilize either the quantitative 72-hour stool fat test or a qualitative Sudan stain to prove a defect exists. Steatorrhea is the most sensitive early indicator because dietary fat requires the most complex, multi-stage enzymatic and transport processes to absorb. If the system is failing anywhere, fat absorption is usually the first mechanism to drop. To separate the phases, we use the D-xylose test. As seen in this split pathway diagram, D-xylose is a simple sugar that bypasses pancreatic enzymes. Because its absorption requires an intact mucosa but operates independently of luminal enzymes, a low D-xylose level points directly to a mucosal defect. A normal level isolates the problem to the luminal phase. Rigorous biochemical confirmation ensures every test ordered answers a specific physiological question, preventing premature reliance on structural imaging. Once a mucosal phase disease is biochemically confirmed, upper GI endoscopy with multiple duodenal biopsies becomes the diagnostic gold standard. This endoscopic view demonstrates what the clinician is looking for macroscopically. Notice the distinct scalloping and the marked loss of normal mucosal folds along the duodenal wall. Secondary macroscopic indicators include overt mucosal nodularity and a generalized flattening of the tissue. Gross visual inspection is insufficient. The definitive differentiation between the underlying causes of this damage relies entirely on histological slides. Looking at this side-by-side H&E stain, the left side displays normal tall villi. The right side reveals severe villus atrophy and an influx of intraepithelial lymphocytes, classic histological hallmarks of celiac disease. Endoscopy takes a broad biochemical suspicion of a mucosal defect and translates it into an actionable, definitive tissue diagnosis. These diagnostic algorithms must adapt to epidemiological realities. Data emerging from major institutions in South Asia, such as the Christian Medical College in Vellore, illustrate a shifting clinical landscape. This map tracks the changing prevalence. While tropical sprue was historically dominant, the community-level prevalence of celiac disease now exceeds 1% in North India. This changing geography informs a critical clinical pivot. What happens when the proximal duodenal biopsies return normal, but the biochemical suspicion of malabsorption remains high? The next step is evaluating the distal bowel using CT or MR enterography. This scan demonstrates distinct mural thickening and strictures further down the GI tract, revealing transmural or submucosal processes but an upper endoscopy cannot reach. In these specific scenarios, the most probable etiologies include distal bowel pathologies like intestinal tuberculosis and Crohn's disease. Geographical etiology and distal bowel evaluation are critical blind spots. They must be investigated when proximal duodenal biopsies fail to provide an answer. Let's trace a rapid clinical decision tree using this physiological funnel. At the top, we input a subclinical patient presenting with isolated refractory iron deficiency. We move to the confirmation step, finding a positive spot stool fat combined with positive TTG IgA serology. We proceed to the localization step. Endoscopy reveals scalloping, and a subsequent biopsy confirms severe villus atrophy. Following this structured logic, the path leads to a final diagnosis of celiac disease. Therapeutic efficacy relies entirely on achieving accurate physiological localization prior to any intervention. Prescribing a gluten-free diet for a patient who has undiagnosed pancreatic insufficiency is a clinical failure. You cannot successfully treat a luminal defect with a mucosal intervention. Precision in malabsorption diagnostics is achieved by anchoring every serological and structural result within a rigorous